Good afternoon, everybody. How's everybody doing?
Very well.
All right, cool beans. I'm hoping that I will put on my reading glasses and this will be an easy peasy party. All right. We have two phenomenal guests. Only one made it to the poster because of our snafu. And so I'm gonna say hello to Dr. Smith. We did a piece with Dr. Tuxson. I know you're looking all over for me. I'm with the green background. And then we've got Dr. Alleyne of NACCHO. And so he's going to join us and talk to us a bit. And so for the two docs who've never been here before, somebody should have probably prepared you. You probably should have maybe gone back to take a look at some of the videos, because this is not your mama's webinar. We don't try to do it that way. And we certainly don't try to kind of hide out what is what. Today, I'm certainly going to give you both an opportunity to introduce yourselves, but I wanted to break the ice a bit, because what I want to talk about is broadband. I want to talk about broadband in rural America. I want to talk about broadband in Appalachia. I want to talk about broadband in urban environments. I want to talk about broadband in Black people's. I want to talk about the digital divide. I want to talk about broadband and farmers. I want to talk about broadband and seedlings. I want to talk about broadband all over the place. I want to talk about what we're going to do to help our community health departments and our county health departments across the United States to be able to implement both behavioral health as well as physical health programs using broadband technology, and what technology is available and how we can be more supportive, which is why I asked Dr. Alleyne to come on here and talk about their broadband work that they're doing with county health departments. But I'm going to be able to start with Dr. Smith, because I think that, I'm trying to figure out how you got all that money for broadband, and I'm looking at that fancy office background. So that means you might have your own satellite at your desk.
Absolutely.
So first things first, welcome to our monthly Rural Health Service Providers meeting. We do this out of a project of Community Education Group. We have a little bit of support from Merck. We have a little bit of support from a couple other partners that allow us to do and develop and expand the Rural Health Service Providers Network. So let's start with Dr. Smith first. And Dr. Alleyne, I hope you're not upset by that, but I'm going to defer to her because I'm just trying to tell you, that wall looked like that's a money wall, man. You see that?
Absolutely
wall?
Not. It's a digital illusion. That is a digital illusion.
Well, can you tell us, Dr. Smith, about your project, a little bit about you, how you got engaged in broadband, and then I'm going to talk to you about a couple other things.
Okay. Well, I'm really more on the telemedicine side. Now, as part of telemedicine, we know that broadband helps us actually implement telemedicine and give care, especially to the places and spaces that most in need about it. 2016, if I recall correctly, underneath the guise of Dr. Mack, received monies from USDA and HRSA grant to initially provide some access point or digital technology for rural areas, and in that way, that portion of the project was more focused on providing mentoring with providers in the rural spaces. And everybody thinks that Morehouse got a lot of money because we just recently received another grant funding, and the purposes of that was for the expansion of medical education, as well as to kind of target some rural sites, looking at their infrastructure and trying to see how we can help with their infrastructure to provide not only that mentoring, that we kind of talked about before as it relates to providers.
I'm sorry, they should have told you I do jump ins, and
yeah,
as long as I don't do a jump out, I think we should all be okay. But so you said you got more money for Southern communities, but did you get money for organizations, other academic institutions, community-based organizations? Who's in that cohort of who you're working with?
So the school received money from USDA, and it was kind of a monies that was put together from the education department, or our graduate medical education, our undergrad medical education, and partner with other places, partner with Centaur and other communities, some rural communities, 3 in particular. And I want to say Pruitt off the top of my head. I'm blanking on the other 2 communities, to try to put together infrastructure, help with that education piece as it relates to our students, but also help with some of the pandemic opioid things that are going on. So this was kind of a build out on what the infrastructure that was put in place by Dr. Mack's camp a few years ago. And so when the new grant monies were kind of released again, the money didn't come to the telemedicine, actually it came to the school. So when the information came out last year at the height of the pandemic, everyone wanted to jump in because the infrastructure was already kind of laid from previous opportunities that earlier, a few years prior, and wanted to expand the things that had already taken place, particularly as it relates to found an opportunity to kind of help with some of the medical education, because one of the things that was uncovered during the pandemic was us being a medical school, we are in the space and place not only to provide care for those communities who are most in need, but also to educate the next group of clinicians. And so one of the gaps that took place with, in the education piece is Dr. Val Montgomery Rice has done an outstanding job in increasing the number for each class size. But for those who aren't familiar, when the pandemic hit, we had trouble placing learners. Grading, various hospital systems shut down. So even in our own clinical sites within Morehouse Healthcare, we weren't, placing learners initially. We had to get innovative, and then we finally start placing the learners in the digital space by leveraging telemedicine, and then eventually we're able to resume them being on clinical sites. But it just the opportunity came at the height of a pandemic, and you also saw gaps that were there. And so part of this is to kind of help fill the void as far as education, providing education for the medical students, providing future placement for them, providing resources, but also to help create opportunities for that community, and then eventually be able to create a pipeline to them into our healthcare system. So
I'm going to stop right there and pivot to Dr. Alleyne, because you bring up what I think is one of the probably most under discussed points, but I think one of the most critical points. Dr. Alleyne has no idea where I'm getting ready to go right now. So he's very, 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 very afraid. So let me just go ahead and pivot over here and say, one of the things I heard Dr. Smith talking about is kind of basically continuing education, or where we're going to place and fill the void that's in particularly rural and southern hospital systems. So, and I also think that this is true with community health centers and with local health departments, because the local and county health departments, because many of these county health departments are the provider of primary or secondary resort. So that's what I wanted to pivot over to Dr. Alleyne, because I also want to make sure we get back to that distinction between broadband, medical visits, and any other sort of care that is delivered through a telehealth or telemedicine system. And I think that those are 3 very distinct things that often get lumped in together. So Dr. Alleyne.
Greetings. Thank you so much for inviting me. Hello, Dr. Smith, and our colleagues from Morehouse. I come from the National Association of County and City Health Officials. We are the national organization that represents the nearly 3,000 local health departments across the country. And as was mentioned, the role that I play as the Chief Program Officer, having spent about 16 years as the Director of Epidemiology in a local health department in New York. Recognizing that there's so much injects that we've had to deal with, shouldn't use injects because there's so much tabs, but more specifically around the role of technology and data. One of the things that we have been very clear in recognizing, both from the past and from several informatics conferences and other work items that we've addressed, we are behind the eight ball with respect to data technology and data integration. There's a reason why there's this huge investment in what's called the Data Modernization Initiative, or DMI, an effort to try to provide data in the hands of those who need to make better informed decisions. But to the point that's raised by Toni and company, we have to also recognize that it's not just saying, how do we get data? How do we get complete information? And what are the systems in place to encourage and promote that? Oftentimes with the Affordable Care Act, what we actually saw was that the investments in data and in electronic health records, et cetera, went to the healthcare sector, the hospitals, the FQHCs, the clinics and the critical access hospitals, for example, and the doctors' offices, but not necessarily to the public health side of the coin, meaning the health departments and the others who are focused on community-based health. And as a result, we've actually grown this disparity, which was very clear and evident once COVID hit. And there's this question, well, wait a minute, there are people who are from certain demographics that are more negatively impacted. Why don't we have better data? So the systems were not developed in that regard. Another piece that we also saw, and this was even typified in a metro center like DC, which has some significant reverberation on the rural side, we were able to identify several points when in an attempt to get vaccinations into communities, especially communities of color or individuals who don't necessarily have the access. The question was, well, there are all these websites that folks can go on. And as you all know, now it's better, but before it was a significant challenge to have folks be able to navigate. And one of the items that was able to easily identify was that you can say you have websites, but do people have access? Do they have enough smartphones or computers or the internet technology, knowing that there's a huge digital divide, to enable them to feel comfortable enough to use these solutions? And as a result, we actually saw that in some jurisdictions, it was really a decision to go hybrid, to make sure that you have an in-person component or a solution that allowed for people to have better access rather than just sticking solely to a digital perspective. Now, with that said, the last point, and I'll turn it over before Toni gets a little antsy about me, is that the third leg of this particular transformation that we have seen around this digital divide has been, as Dr. Smith has mentioned, the growth and the proliferation of telemedicine. By virtue of us being shut down, by not being able to access health in the way we normally would, dealing with issues such as transportation in rural settings, as well as ease of access to clinicians and others, the telemedicine world essentially did grow and show that there's a need for it and a need to build sustainable models that both ensure both the provision of services and the access to quality care. So I'll pause there for this moment.
All right. Thanks, Dr. Alleyne, because you kind of paused. You look at you're reading my brain, I think, and that's a dangerous thing for you for a whole bunch of reasons. Some stuff you should just keep to yourself if you're actually reading my mind. But Dr. Smith, I want to come back to this. What I see is an iterative process, right? So you're at Morehouse, at HBCU. Mm-hmm. And so when we look at broadband access across rural communities, rural Southern communities, what I'd like to have started talking about, and we do more and more talking about it, is a vulnerability index, right? Mm-hmm. And I think a part of kind of looking at America's most vulnerable populations, I think that we have to do things like certainly look at where they fall on the, poverty, any sort of poverty indexes, but also whether or not they have access to broadband, period. And have you guys done, I'm sorry, I'm using guys, but has Morehouse done any sort of work around looking at mapping of the United States? Because I know that, one of the things that we've been talking to a couple other federal agencies about is about how bad the dead zone map is in the United States for broadband, and it really all needs to be redone. So I didn't know if you had any information you could share with us about who has broadband, who doesn't have broadband, and because if I don't have that, I can't get to you all the good telehealth juice that we need. And if you don't have it, how do we get it?
So we have not done a map as it relates to the dead spaces. Now, in 2015, one of the Federal Communications Commissions, they placed a limit of what qualifies as broadband, right? So it's like 25 Mbps, which allows you to have a sustainable amount of broadband to facilitate web browsing as well as video, which, again, impacts me as a clinician who's, does telemedicine. So I need to have a substantial amount of video access to have telemedicine and do the video audio component of things. We do have information as regards to Georgia, knowing that 70% of Georgia where, there it does not meet that mark happens in rural communities, and about 10.1% of Georgia have that. But we have not personally done research looking at the map as it relates to the United States. However, I think that, again, and I know I'm kind of bringing it back to COVID, but I think that COVID continued to provide gaps in terms of digital divide as well as health disparities that we all knew about, but it just became more germane and tangible in our faces. Of course, we talk about, the health issues and all the things that came about as it relates to medicine. But going back to the education piece, we know that there were a lot of students who suffer as it related to being able to keep up in the digital space and virtual learning. We heard stories about students and their parents having to go to Walmart parking lots in order to complete assignments. So I know that in October of 2020, Brian Kemp, signed some orders to help get more privatized utilization and more partnering to expand the broadband so that those gaps are filled in the future as it relates to broadband services. And I'm sure that there's legislature across the country, doing the same thing. Again, not just because of the telemedicine medical component of it, but again, in that virtual world, when we had so many students who were doing virtual learning, that's a whole nother topic in terms of other gaps that, came about. But we know that a lot of people were behind, a lot of kids were behind because of that privilege, if you will, to have adequate broadband.
Okay. All right. Dr. Alleyne, you've been sticking stuff in the chat and cutting and pasting from the FCC, and why don't you tell the people what you're talking about?
So the FCC, for the first time, and I think this is a few years back, they hired an epidemiologist where they're actually able to both look at the data around broadband and tie it into some health indicators. So to Dr. Smith's point, this is pre-COVID, but I put some links on there so you could actually see a number of these maps and have the ability to add some of the health indicators by rurality and by county, which really talks about, to your question as well, around what data is out there, what at least we know from the FCC perspective, and how you can use this to leverage both the collective understanding and the improved awareness around access points. Even for us, we have a survey that we do, which we try to really address from our membership perspective, local health departments, about what are the data needs that local health departments have. And when you look at small, medium to large, we actually find that our small jurisdictions are not as really great developed with respect to having these data access points or these systems that work together. And the fact of the matter is, when you're either small, medium, large, this really tells us that the disparity does exist, and we need to figure out a way to bring everyone up to snuff with respect to gaining access and to be able to leverage these tools for our overall benefit and health outcomes.
Oh, okay, so I want to flip this a little bit because, and I'm going to get all y'all in trouble. I hope y'all have job security. So here's my thing. Is it not that broadband and telehealth are infrastructure issues? Why are we not seeing more of a push for both the new infrastructure bill and, well, I think it was CARES Act 16 was the last bill that got passed with COVID. We started out 1, 2, I think we're at bill number 16 now or something. That had some money in it for broadband. But if we are going to really address health conditions in rural communities, we have got to make this an infrastructure issue. This isn't a luxury item anymore. This is a utility. We need to ensure that the poorest and most vulnerable of American citizens have access to broadband and telehealth and more. Again, as these hospitals are closing, or as Dr. Smith, as you pointed out, we saw the same thing in West Virginia, that folks that didn't have broadband were going either to the library, which has limited hours, and then many of them closed down. But then you also had that they had to go to a parking lot or to a cousin's house to access broadband. They couldn't always use their phones as hotspots. That wasn't working in many conditions, again, because we're at the first phase of broadband, which was related to just, can my phone work? I mean, my cell phone doesn't work in my house here. I have to have a micro tower. I mean, and many people don't even know you can buy a micro tower. So, Dr. Smith, go ahead. Tell me what the politics behind this one is.
Well, I mean, it is an infrastructure issue. And again, when it impacts, so I'll go back to telemedicine, right? And this is an example that I give often just because, it hit home. So with telemedicine prior to COVID, again, I use that as a landmark. Telemedicine has been around for a very long time in some way. So let's just start there. But it was, as it relates to how it's utilized now that we know of it, it wasn't something that was broadly utilized because of all of the loops and hoops we had to jump through as clinicians as it relates to, reimbursement. Certain insurances, you require to utilize this particular telemedicine company. Medicaid for Georgia, you have to be at a presenting site. So if my patient can't get to the site to present, how are they going to have access to telemedicine? Certain insurances wouldn't pay for it. Literally, it was layer after layer after layer. Now, prior to COVID, things were starting to, turn the corner, but it was a very slow turn. Okay. And when COVID hit, the floodgates open, right? So everybody was utilizing telemedicine. All the restrictions, you didn't even have to utilize a HIPAA compliant platform. They just wanted you to have that access. And so you still dealt with, if you recall, summer of last year when Medicare made their revisions in terms of, the G2012 code, the new telephone code, some of the things around reimbursement. They gave more monies for telephone only. Well, there was a reason behind that, right? So one had to do with some of the our population not being able to navigate telemedicine. Part of it was talking about the infrastructure. So, if just like you said, that your phone doesn't work in your home, some of our elderly patients who are in rural places, their phones and things like that, they don't even know how to navigate the web. So again, being able to pick up the telephone and utilize telephone was the way that we were able to conduct care. And so I say all that to say, we've known that it was an infrastructure issue, but we live in a reactive society, right? And not a proactive society. There was data pieces prior to this that showed that there were better outcomes when we were leveraging remote patient monitoring and the patients had access on a more frequent basis. We had the information as it relates to the mileage that patients had to travel in order to have care. And especially in Georgia, where there were hospitals and places closing down, we already knew that there was a huge gap in terms of, patients being able to just travel for the most minute things. And so we as a society, we as, America is supposed to be leading the forefront of health and equity and all these other things. We drop the ball a lot of times because we react. And so now, everybody, again, because it impacted the people who were privileged enough to have the right type of insurance or privileged enough to, be able to pay cash for telemedicine visits. Now, when their family member or cousin or things of that sort were impacted by what took place with COVID, when their kids are impacted because, or their, neighbors' kids or whoever the family members were impacted, now something it becomes an issue or something that's a priority as it relates to policy. And so again, we have the national, federal things, and we have funding that's being released to try to, be able to, the flexibility to be able to utilize some of those resources to look at, infrastructure, how to put those things into place. But then you also have on a state level where, again, I referenced some of the things that Brian Kemp signed, and he's kind of talked about in 2020 as it relates to trying to fill in the voids as it relates to infrastructure. Now, what the best means to fill the voids are, is it to privatize things? I mean, I can't answer that question, because again, you sometimes get into the have and have nots, and people making money off of something that should be like a basic necessity at this point, right? Or should it be something that just is funded by our state and local government systems? So before I get into trouble, I'm just going to pass the mic.
All right, we're not in trouble yet. I'll let you know in trouble when we're in trouble. And there are people on this call that would say you probably don't want to follow Toni on that one. Like the trouble line is something I usually have jumped over long before others. So we'll be all right. We'll be all right if we get in trouble together. I mean, you can stay here for a little while till you get back up on your feet. All right, Dr. Alleyne.
So one of the things I want to add to the conversation has been, to your point around where's the investment? Why is it out in infrastructure? Now, ironically, when you look at the American Rescue Plan, they have earmarked around $130.2 billion, which they said is for counties and cities fiscal relief. And they actually said that those dollars, which was, were out in early May 20, they had four categories. The third category was provide government services in a way that covers the revenue gaps created. Number 4, make necessary investments into water, sewer, or broadband infrastructure. Very clearly stated that $130.2 billion, $65 billion for cities and counties specifically called out, does have the capacity to address broadband infrastructure in the fiscal relief plan. And I'm happy to, I'll keep dropping links as I can all day into this thing. But you can look it up and you can see where these elements are being discussed. Now, the other point to your question, when we say, well, is there investment in, and why is it not in the infrastructure bill? I would say that I can't speak to these legislators and how the appropriators work things out, but I can tell you that I would probably reconcile it that they place some of these investments in other legislative buckets and are still toying around with the back and forth as to what infrastructure means. For us, we say infrastructure is not just bridges and tunnels, it's also people. And it's also the data and the elements needed to strengthen that. The Data Modernization Initiative and the Funded for Data Modernization, which is also a federal, state, and local initiative, also, in my estimation, does have some language in there around data modernization, building the tech infrastructure to really support the day-to-day needs that our communities are seeing. So while you may not see it in this, it may actually have appeared in that. And it's a matter of, unfortunately, combing through the various documents to really pull it out and see where it's clearly earmarked versus it being in a bundle that we obviously would say, if it's infrastructure, it should go there. But as you can clearly see, the infrastructure bill in of itself is being argued every way to Sunday.
Right. So again, I'm going to kind of come back to this in terms of, the reason that we're here, is reality. And one of the things that I keep worrying about or keep not seeing is us having a conversation about this investment. Because I think that one of the things that we don't know the answer to yet is, what does the future hold? As much as I like to rub a crystal ball and tell people I can see the future, the truth is that I cannot. So if we are going to move forward in public health, what is going to be the future of telemedicine and telehealth, right? So, I think that they said that something like the percentage of telehealth visits, kind of increased by like over 800 times or something as a result of COVID. So are the federales going to say, hey, get back into the box, and here are the only times that we're going to cover for a telehealth or telemedicine visit? What are the other challenges that we're going to see that are going to attack how people have now been getting healthcare services for the past year? And, speaking of gaps, again, I keep coming back to over 100 rural hospitals are closing. Now we know, we want to call federally qualified health centers, community health centers. And if you're talking, depending on how rural that area is, that might be a 2-hour, 3-hour drive. So where are we going to integrate transportation into this conversation about broadband, telehealth, and telemedicine? But I keep coming back to, that's the part that scares me the most. When we wake up one day, and we will, and I think we will relatively soon, wake up and the federal government says, guess what? We're not paying for a vaccine no more. You should have got one when we had it. You should have got in line when we told you to get in line. And now what we're going to do? Because now you're going to have the same, I think, group of people who have been often left out, disenfranchised, whether that's disenfranchised as a voter, disenfranchised as a health, receiving appropriate health care. That individual will not be able to access services if we don't sustain telehealth and telemedicine and increase our broadband services. What's my question in there? I don't know. Y'all need to rub your crystal balls and tell me what's getting ready to happen so I can prepare the people.
Well, I'll start as it relates to telehealth and telemedicine. I think that there's going to be, so first of all, telehealth and telemedicine aren't going anywhere. If anything, it's going to become more sophisticated in terms of the way it's delivered. That is evident by the monies that are being put towards remote patient monitoring, because it allows for better data and better outcomes. What relates to remote patient monitoring, telemedicine, we think about, get on the doc, do a virtual visit with our doc, they give us recommendations and things of that sort. But as it relates to remote patient monitoring, where the doctor is able to see, the spikes in blood pressure and blood glucose and things of that sort, it's adding that other piece that helps with the medical decision making. It also makes it more comfortable for the provider. You're going to have more labs and state bases in places adding to the telemedicine community. You already have abundance of various companies with peripherals. If you go on Instagram or any social for our millennials or Generation Z, X, I'm not sure which generation we're in right now, but you'll see ads for peripheral devices where you just say, hey, get the otoscope, let me you can put it in your baby's ear. The baby's able to have a virtual visit with their moms. Now, I don't think that level of sophistication as it relates to peripherals is going to be available for everybody at every home. But again, telemedicine is growing that way. The issue is going to come in terms of the regulation and the payer parity that's taking place. Supposedly last year when CMS came out with those guidelines, they're supposed to bring telephone visits and things like that up to speed to make sure that they're paid at the same or equal rates as in-person visits. The second thing is, if you remember, there was a relaxation on, using HIPAA compliant platforms and all these types of things. So the issue that's going to lie with COVID is, being able to regulate people doing things the right way, meaning that, are we still going to pay for you to have a telephone visit when you're billing for a 99214, but you only spoke to the person for 1 minute? And so some of the things that are being juggled and fought over right now is to look at, some places are making it where you have to show that you attempted to at least do an audio visual before you revert it to the telephone visit. So that you see how they're starting to pull back and add some of those regulations, even from what was relaxed during, we're still in COVID times, but, the height of COVID in that way. So there are going to be regulations as it relates to telemedicine, mostly with the outpatient delivery of telemedicine. But from a technology side, that's going to continue to expand. It's just a question about who's going to have the ability to access all of those fancy new things that are coming down the pipes. As it relates to hospitals and telemedicine has been a big gap filler even prior to COVID with hospitals. With teleneuro, our hospital was already on teleneuro before COVID hit. So those places and spaces that don't necessarily have access to the specialists, it has been very much utilized and leveraged in that way. And I think that some of the monies that were being poured into hospitals to keep them open during the height of COVID because out of necessity is going to prove to be a benefit. And they're going to understand that, you just can't wipe out a whole hospital, we're on the brink of our next pandemic or the next thing. We have to figure out ways to work through them in order to not end up in the situation that we were at the height of COVID. So I hope I answered one of the questions within your questions.
Yeah, I mean, I don't know if it was really, you did. I don't know if it was really a question. Like I said, somebody should have warned you before you got on here. It's usually just my brain opens up and I start thinking of stuff. Go ahead, Dr. Alleyne.
So what I'll add to the conversation, and you mentioned I've been dropping a lot of things in the chat. So forgive me for a minute. I'm just going to see if this thing is working here. Sorry, I had this all lined up. There we go. So not the last one I put, the one on ASTO, and I'm going to, okay, let me just show this to you guys for a second.
Marcus, can you give him, make sure
I got it. So I want to show you a few things, and this is specific to the funding that has been rolled out, feds and et cetera, and who all these target folks are. Now, there's the crisis response, there's workforce. I'm going to go very quickly as rapidly as Toni talked. So just looking at these perspectives: rural testing, rural areas, rural health clinic testing mitigation, rural health clinic vaccine confidence, 398 million, 460 million, 100 million, right? Continuing again, and just bear with me, there's a reason for my madness. There's the 2.25 billion to address disparities in underserved and minority and rural communities, right? Community health workers, 32 million, 300 million for resilient communities and response. You have social behaviors, 750,000, but it's going to get to certain elements that I want to quickly underscore this point. Workforce of vaccine access, local recovery of funds. But one other thing, mental health and the funding's there for that. But I want to get to some of the other elements that I think, for example, here, the farm service, agency programs and services, 2 million for that. Additionally, there's vaccine efforts around health literacy, equity. Of course, we have where's page 12? Page 12 has it for me. Rural community facilities program grants and disparities in testing. My point, and that's 500 million. My point is, to your point, Toni, right, around, how do we address these upstream elements in a way that's going to be impactful and mindful? And the concern is, well, how do we sustain it while at the same time building? What is the future for public health? One of the big fear factors that we have is that everyone's going to say, you got a boatload of money now. You can't complain that money didn't come. Money has been flowing. Money has gotten to all these places, but it wasn't spent properly and you didn't do anything with it. Meaning we can't do things in the way they've always been done. We can't just say, okay, we got money now. Let's just hire, 10 people. We have to do it smartly. We have to think, to your same point, what is it that we need to accomplish? What does the public health system for the future look like? How do people access care? And how do we build systems that are not just going to be waiting on this one time or 2-year or 1-year infusion of funds, but that maintain a sustainability model that's not always disease specific. You don't just get diabetes money, you get HIV money, you get this money, that we're getting public health or health systems money. So that's one of the areas that I think has been critical to the conversation as to where we move while still addressing the response efforts for COVID, but recognizing that once COVID is subsided, we're going to have all these other issues that we all recognize that have always been on the forefront and the tips of our tongues, but we really now can't really make an excuse. We have to galvanize ourselves to ensure we're making the right investments with the right forward-thinking mentality to ensure that these systems are sustainable, which includes the broadband, which includes the telemedicine, and the basically all hands on deck approach into how we engender public health.
Okay, you talk. I don't talk that fast, so I don't even know what you're talking about. I heard you throw that in there. You heard him too, didn't you, Dr. Smith? You're like, oh, yeah. You heard him, right?
He said, y'all got your money. Go ahead and use it.
Well, I mean, and so the first thing is I got 2 texts. Can you make sure you get the link to that whole chart? Because the people were like, where did he get all of that from?
That's in the chat. That's all these things. Everything I put is in the chat.
Okay, so Marcus, can you make sure that you or Amanda that you pull that out so we can email it out to everybody that's on the call? Because if one more person texts me about that chart, I'm gonna scream. But here's the thing. The money's flowing. Right. Money's out there. Now we're not going to get into who got the money and who didn't get the money and what. Yeah, Dr. Smith said, I do want to talk about who got the money.
No. I was going to say, I know where you're going with this.
Where am I going? You go. You see. Let's see if you going where I was going to go. You go.
I mean, I think the money's out there, but who knows about the money and knows how to obtain it? And I think that's the biggest gap that we've always historically had in places where people underserved. Is, part of it is having the money, but having access, being educated that it's there, because it have a tendency to fall in the same hands. You wonder why this hospital always has X, Y, and Z. Well, they have the knowledge, they have people positioned in places to understand how to ascertain those funds. Whereas where you have the community workers or our public health people, who've got their MPHs and they're out in the community, they have no idea how to touch the funds. And these are the ones who really know what is going on. They're the health advocates. They're there in the trenches, and they would know how best to address because they have an idea of the needs. They've done those assessments of those communities, but they don't know how to get to it.
Right. So I was going to go partially there around access, and the other place I was going to go with two other places. One is, how do we make those investments? Where should we be looking to invest? You, Dr. Alleyne, say, we've got to invest in this, and this. But I think, to be really specific, what do we need to be investing in? Should we be investing more in those on the ground community partnerships and collaborations? Should we be investing more in workforce development? I mean, take some place like West Virginia. I can have a project manager in West Virginia. That salary might be, I'm making up numbers, don't anybody on the CEG team listen to any of this, that could be making $50,000 in West Virginia. The same job is $85,000 in DC, Maryland, or Virginia, right over the line. So we've also got to make an investment into our public health professionals in the state, but also we've got to level these salaries out that people can just move to other places in the region. So I think that's also access. I think all of this is about access to money, access to services, access to qualified healthcare professionals, access to information, access to health literacy, access. So where do we make the investment? Again, I'm flipping around, but you take a state like West Virginia, right, which is in the middle of an HIV outbreak, it has a history, long history of leading in fatal overdoses and substance use, number of people impacted by substance use disorder, and been number 1 or number 2 for Hep B and Hep C, and Hep A is coming up right behind it. So I'm in West Virginia with this, torrent, if you will, of health outcomes that are all negative. Where do I make the investment? A state like West Virginia with this challenge is not a part of the ending the epidemic solution. Senators Capito and Senator Manchin have said they now want West Virginia in EHE as soon as humanly possible. My problem with that is that that's like those old puzzles that you used to have, those old Chinese puzzles. Remember, you used to get them, and you had to move the little tile piece around in the little. We've got to be moving HIV, Hep C, Hep B, HIV, substance use disorder, COVID, transportation imbalance, health equity, education, access. I mean, there's a lot that's got to move all at the same time. So you tell me, do I make the investment in surveillance? Do I make the investment in community partnerships? Do I make the investment in making sure every house has, broadband in front of it? It's a lot. And I don't think that I'm just seeing this here in West Virginia. I think that we're seeing also some federal regulations and state regulations that are doing things like pulling back on harm reduction laws. So I think we're going to see another outbreak pop up in Indiana if that law passes. I think we're seeing higher rates of infection around HIV and other issues throughout Appalachia. Where do we make the investment? what can we, what do we do? How do I help the people help themselves?
It's all of the above.
Listen,
It has to be all of the above, right? Because we can't do one and not the other. It is virtually impossible. And I think that model of doing one without the other has been problematic. That's why some people are left behind, some others don't have access. In fact, the comment that I made in the chat was that with respect to, as you talked about, well, who gets access to what? That's something that we've even been trying to address. An investment in people, an investment in the infrastructure doesn't just mean bridges and tunnels and technology, right? We have to train people so that they are competitive. The reason why some groups get more, because they are, I'll say it this way, they have well-oiled machines, they have their grant writers, they have their processes, their administrative experience. And then we also recognize that when you go for RFPs, some people are not competitive because they don't have the experience of dealing with large bolus of federal funded. They don't have that. They don't know the rules. So how do you bring people all up to the same level so that there isn't disparity even amongst those who want to do the good work? And that's where you have to help train and make investments to say, we will earmark such and such, or we will provide training so that you can become better grant writers. You can become better, project managers and understanding how to manage federal budgets. Otherwise, it's always going to be those who've had a high success rate, a well-oiled and mature systems that will continue to be able to gain access, because it's a lot of trouble to follow behind people to make sure your invoicing is done right, or that you're doing this reporting, or addressing these audit potentials. So those are all things that, as well as it may sound to say, just get folks access, the investment into both building those skill sets and developing those criteria so that they can be equally competitive to provide the work that's necessary for the community. And recognizing that when I say all of the above, I'm not trying to be glib, but it's really all of these things need to happen if we're going to come into a whole health perspective. The emphasis on genomic sequencing, on DNA, on health systems, on community integration, on workforce, right? We're losing so many public health workers that before COVID and even as a result of COVID. So how do we embrace all of these investments in schools and social terms of health, and addressing structural racism in all of these, fiscal and other compliant, concerns? It has to be an all of the above approach.
I'm going to add to that conversation that, and you can tell her I said this, not for brownie points, but this just is my truth. Dr. Valerie Montgomery Rice. If I could take Dr. Valerie Montgomery Rice and multiply her by 20 and put her in different spaces and places and give her resources, I would. The reason I say that is because in 2015, 2016, Morehouse School of Medicine got $35 million. And she had the foresight and the aptitude to know that I'm not going to, and part $35 million from the governor deal at that time was to help, help bridge the gap in the health disparities in rural environments. So she had the fortitude to do all of the above with 35 million. And hindsight, 35 million isn't a lot to do all of the above, but she did as much as she possibly could. And so one, she said, hey, we got to increase the workforce. So she increased the medical school class size from 56 to 100. I graduated from Morehouse School of Medicine, we were in class size 56. And then utilized part of that funding to create a PA program. The second thing she did was create the innovation. She put money in a pot for innovation. So that was simulation labs that Morehouse School of Medicine did not have before, that went towards the training. That was telemedicine. So that's where we got our bucket. Prior to COVID, we were doing telemedicine. And then that was innovation as it relates to research. So funding research projects for people of color. The other part that she did was trying to make sure that we sustain workforce that's, medical, graduate medical education as it relates to MPH, as well as residents in these rural communities. So if you decided to stay in the rural community, she gave so many scholarships a year for you to stay for loan for forgiveness. So $25,000 a year was given to loan for forgiveness for 2 years for people who stayed in those communities. And then the other portion of it, she started to put the footwork into place to build out an MPH school, or a public health school of medicine that's going to come down the pipes. So again, $35 million doing all of those things, in hindsight, isn't a lot of money, but she definitely made it stretch. And so to the point of my colleague and yourself, again, all the things need to be done. There's so many things need to be done, but you have to have foresight, you have to have organization, and put the right pieces in place to, hey, we're going to do this the wheel, right? We're going to have a wheel here, a spoke here, a spoke here, a spoke here. And that's going to get us to that center and position where our target is to come at the end of the day to have those health outcomes. And so to my colleague, everything, you have to have it all in order to really push forward.
All right. So we are at about 10 minutes. I should put my reading glasses on. We're at about 10 minutes to the end of our time together today. If anybody has a question, please pop it into the chat there. But what I wanted to kind of leave on is, what would you say if I said, we're going to open up the checkbook of the federal government? Money's not an issue. We're gonna write. You can write whatever. I got some people who know some people.
No limit.
No limit. You got no limit. Tell me what the program. Hang on. I'm gonna get on what the program is that gets us access in rural communities, that gets us access in the hollers and the halls of West Virginia to downtown Atlanta, right? To all the Appalachia region. We got to deal with overdoses right now. We've got to deal with kids accessing school right now. We've got to deal with this, I think certainly with the professional development opportunities that you're talking about, the public health issues, HIV, substance use, hepatitis. I got to do that. I need your plan. What's your plan? Tell me the plan. I know it's all the above. I heard you. But now we talk. We in the kitchen. It's about 4 o'clock in the morning. We've been playing cards. Now tell me how we gonna fix it.
We're drinking, or no? It's with alcohol.
I don't drink, but you know I'm a good hostess, so you know everybody got liquor. So everybody red cupped up. Now, look, I know some people that know some people that know the people. How we gonna fix this thing?
So, yeah,
whoever will.
Well, so how to fix is more than just the dollars, and that's the flow, right? So when especially as we're talking about a full comprehensive investment, looking across all spectrums of industry. Right now, we've been talking about the public health or the healthcare sector, recognizing that there's that there's connectivity there, that's a concern. We've also talked about the data modernization efforts, whether it's federal, state, local, municipal, even public-private partnerships. So respective of where the money is coming from, it is sticking together with respect to understanding that you have work plans, you have to work in collaboration, that you need to hit your targets, and you should sit down to say, we are bringing this to the table. This is how we're going to approach this particular set of indicators. We recognize that this has another component that's going to be helpful, whether it's transportation, substance or emergency housing or housing in general. What are the policies that are in place to ensure that we have both the recruitment strategies helpful for building the workforce, looking at the next generation with schools, focusing on schools so that they're changing their curriculum to be more encompassing of an equity lens, and understanding what that means, whether it's in science, technology, or social services, or whatever, or medicine, whatever it may be. So it's, when you say, where do we go and what is the plan? The plan is essentially, we have this, we've been, the last year, we've been hit with this club. So now we have to realize, what do we do to both build our defenses and also be thoughtful as far as how we want to plan in a way that is going to ensure that we can be successful.
I agree. I am, obviously physician. I see so many things, but telemedicine is my thing as well. So I would look at the communities, I would go into the schools, I would address some of the basic social determinants that impact health outcomes, right? So, food insecurities, some of the financial security issues that we have in these communities, creating job awareness, because we do know that there is a huge disparity as it relates to health literacy. So I would start at the ground. I would start from the beginning, and then from the top coming down as it relates to funding, is making sure that we have the infrastructure in place that we've already been talking about this entire time as it relates to broadband technology, making sure that there are, if I were able to do it in multiple ways to reach the patients, mobile services going out to the communities, leveraging telemedicine. We know that it works, but making telemedicine more sophisticated in regards to the peripherals that are available for people, the remote patient monitoring that are available for various people. But then also, as we've all talked about, is making sure that we put monies into educating and advertising what is available, and really you have to advertise in various ways, not just putting something on the CDC website or HRSA website and things of that sort. That's billboards, that's Instagram, that's being innovative with how we approach and putting the information out there for what we're offering and then the education we're offering. And then the last thing I add, because my colleagues already talked about it, free school for everybody. Maybe that's just me being the physician. Clear all those student loans and let that not be a barrier, so that people are in space and places and able to really, live a lifestyle and be able to have those less restrictions and be able to serve in those communities that are most in need. So I think if I had a checkbook, there's everything I would address, but I definitely start off with, the communities at the community base, and then work from the top down.
Wow. Well, I certainly want to thank you. One of the comments in the chat was that someone suggested that we have Senator Capito and Senator Manchin here, and actually we are, and I think that was Sherry. We're actually working on a kind of a bigger project where we will be inviting you all and Senator Capito and Senator Manchin, and we're asking for representation also to come in from the White House, because we think that this is a huge issue, and we think that it is the issue that kind of weaves all of this together. And actually, it weaves it together, and it's the foundation. If we don't get this right, I fear that it will impact so many other things in West Virginia. When I say get this right, I mean how we integrate or reintegrate broadband, telehealth, telemedicine, from everything from utilization and education of consumers, but how we also make sure and keep our eye on what Medicaid reimbursements are looking like. Because if physicians can't get that reimbursement, I think they say, you know what, come in for a patient visit. If you can't get in here for a patient visit, then you can't get care. I don't know what to tell you. And so we have to then talk about transportation. And I think I got it, Dr. Alleyne. It is all. And I think that what I've got to do and what we've all got to do is help Senator Manchin and Senator Capito to see that all of these things work together. And that we need, I think, also in this moment, special projects of national significance and demonstration projects. And we've got to bring those back, I think, as we say in the hood, with the quickness. They need to bring them back with the quickness. And I need a couple of earmarks with the quickness. And because I think that that's where we are for, again, some of the most vulnerable populations in the United States of America. They can't wait a year to see how it shakes out. They can't wait 6 months to see how it shakes out, because that's one of the things, we didn't talk about with too much detail, but Dr. Smith, you brought it up and you hit on it, is that the number of food deserts that are both in urban and rural communities, that we've got to figure this out. And a part of helping get food to where it needs to be is broadband. That's, how food moves in trucks and in systems. It's all connected all the way around. So we are right at 3:00. I want to thank you both for joining us today. Most importantly, I thank you for, being able to indulge me for an hour with my crazy questions and style of asking. But I think that you certainly have educated me, highlighting what you all do. Thanks to Morehouse. I do expect a sweatshirt from Morehouse School of Medicine. For saying, my
Tell me
mom,
your size. I got you.
I need a 2X, but don't tell my trainer. My mom said, closed mouth, don't get fed. So here we go. Again, thank you, Dr. Allen. Thank you, Dr. Smith. And again, folks, if you want to reach out, we'll have their information for you. And I definitely will be reaching back out to you with other projects that we're working on right now. Thank you. Everybody have a great week. Thanks to the CEG team and RHSPN team for getting this all done. Thank you.